Need to study on the go? Stay engaged and on track with the Osmosis mobile app. Access thousands of concise, visually engaging videos, questions, high-yield notes, decision-making trees, and more, anytime, anywhere, online or offline. Download it today on the App Store or Play Store. Visit osms.it/rtl-mobile to learn more.
Hi, I'm Shiv Gaglani, welcoming you to Raise the Line with Osmosis from Elsevier, an ongoing exploration about how to improve health and healthcare. Today, I'm delighted to welcome Dr. Bennett Nemser, who is the Chief Program Officer at the Steven and Alexandra Cohen Foundation. In that role, he manages the foundation's various health portfolios, including the Cohen Psychedelic Research and Health Initiative and the Cohen Lyme and tick-borne disease initiative. Dr. Nemser has a PhD in public health with extensive experience in global health systems in developing countries and related research. Prior to joining the foundation, Ben was a senior monitoring and evaluation consultant for UNICEF and the World Health Organization, and worked for Columbia University as an epidemiologist and data systems manager. He also holds a master's degree in business administration. So Ben, thanks for taking the time to speak with us today.
Of course. Thank you so much for having me.
So the first time we spoke, I was pretty impressed with your background in global health. We also shared some time living in Africa. For our audience's sake, would you mind giving them some career highlights, including what got you interested in public health? You got your MBA as well, and then how you got into epidemiology.
Yeah, sure. So after school, after I got my MBA, I started my career in Rhode Island state government. It was after the dot-com bubble burst, and I was up in Rhode Island. And, I just had sort of been more aligned and more interested in public service, nonprofit space. And so I ended up getting a job as a legislative budget analyst for the House of Representatives there in Rhode Island. This is definitely not something I foresaw myself doing. So it's definitely a learning experience. And I got lucky, stroke of luck. They gave me one of the agencies that I had to analyze and provide an evaluation and recommendations to the legislature was the Department of Health. And so I dug into all their programs and how they were spending their money. That's kind of like my first foray into public health. And a few years later, I ended up at a position with the Rhode Island Treasury, which was a great position. But I was, sort of in a windowless office, crunching numbers in Excel. Which, again, I love crunching numbers in Excel. I'm a very big fan of Excel spreadsheets. But I kind of wanted something different for myself, and so I had that mid-20s inflection point. Like, what do I do now? And so I decided to go back to school for public health, and I was my most interested in global public health. So I applied to Columbia and got in, and sort of went on my way to Columbia. That turned into my internship between my first and second year was in Rwanda with the Earth Institute. So I was working on integrated rural development projects there, and they ended up hiring me after I graduated. And so, started working for Columbia. It was a large project across about 10 African countries, doing, work in healthcare, education, infrastructure, agriculture, and I was working on the M&E team, monitoring and evaluation team. So I was doing all the sort of the survey work and outcome monitoring, designing text-based messaging systems for CHWs to track patients in rural communities with no internet access. It was all very fascinating work, and obviously, we're trying to have a big impact in those rural communities to help them lift these communities and families out of poverty.
Yeah, what an incredible transition from Rhode Island and the Department of Treasury to then living in Africa for some time. When we connected, I think I had just come back from our trip to Kilimanjaro, raising awareness for rare diseases with the Year of the Zebra campaign, and then visiting our partners in Butaro, Rwanda, at Partners in Health and the University of Global Health Equity, which is a podcast we did as well. I'm curious, how long were you in Africa for? And then what were some of the highlights, maybe both professionally and personally, that you were most proud of?
That's a good question. I mean, I guess my career spanned about 10 years working in sub-Saharan Africa. I mean, most of it was New York based. And so I would be going for weeks, months at a time. I was never based in Africa for more than 2 or 3 months. And so after I had basically worked with Columbia, I kind of moved over to the UN as a global health practitioner. One of the dream jobs is working with UNICEF. So I started at the UN Special Envoy, and then UNICEF and the WHO, mostly working on a project for maternal newborn child health commodities. So these are low cost commodities, antibiotics, birth control, etc., and getting those to communities across sub-Saharan Africa. Oftentimes, again, they're incredibly inexpensive. We're talking pennies, maybe $1, but it has to be at the right place at the right time when a woman is giving birth or when the neonate needs it. Otherwise, it's going to be ineffective, right? So trying to figure out how we can do those and partner with these countries to do it most effectively. And then on to sort of some maternal newborn health quality of care initiatives at WHO. It's hard to pick particular highlights out of 10 years. There's so many good memories associated with that.
Yeah, no, I can imagine. That's definitely close to our heart at Osmosis because, as we talked about, I was born in Namibia, and we've given a lot of free access to Osmosis as a learning platform across sub-Saharan Africa, as well as other regions in need. So really, I think we bonded a bit over that experience that you had there as well. Maybe if you pick just one personal highlight, like was it a Serengeti tour, or for me, obviously the Kilimanjaro trip was a big highlight. But yeah, we like to humanize our guests and the work they do too, because you still have other things you do beyond work. So anything that really stands out as a favorite personal memory in Africa?
A fun one was when I was in Rwanda, I had brought my then girlfriend over, now wife, and it just so happens that a colleague's cousin was getting married to someone from Canada, and they couldn't bring over any family members. And so they asked me if I would be his best man. And so with my wife there and myself, we were basically in this traditional Rwandan wedding, having basically just met them the day before. So it was quite funny and a good sort of like cultural exchange moment.
That's amazing. I wonder if you had to give the toast in Swahili or something.
No, but I did do a little dancing. My wife still ribbed me for it. I got a lot of chuckles associated with that. It was a good time.
So we'll drop the YouTube video of Ben dancing at the Rwandan wedding in our show links. All right, we'll get that in a bit. So moving from the work you were doing for the UN, the WHO in Africa, to the Steven Alexandra Cohen Foundation, maybe you can tell us about that jump, that career transition, and then kind of what you started doing at the Cohen Foundation and how it's evolved.
My initial work at the Cohen Foundation was I was hired to manage the Lyme and tick-borne disease portfolio. So they were looking with someone with a background in healthcare, but also had personal connection to Lyme and tick-borne disease, which I am a caregiver for a family member. And I think it was a really good fit because a lot of the stuff that I was doing in Africa was around systems building. And oftentimes that's what's needed in some of these areas like Lyme and tick-borne disease. And now I've sort of expanded out to our entire health portfolio, including psychedelics. Is we're not just looking at one thing, right? You're looking at the entire system, like what are the like the inputs that are going into the system, the financial resources, the human resources, the skills, the quality of other inputs, whether it's commodities or treatments, and how are those actually being delivered to people? So it's around access, demand generation, safety. So really taking a lot of the lessons that I learned during my time, particularly with the UN, over to the Cohen Foundation has been really beneficial.
When I first, again, was introduced to you, I was pretty impressed with the kind of the scope of activities, as well as obviously the funding that the Cohen Foundation has given out to so many groups. Many of the guests we've had on the podcast before I even met you were people whose work, their research, or their clinical care has been made possible through you and the Cohen Foundation. So examples include Fred Barrett, who runs the Hopkins Center for Psychedelic and Consciousness Research, Michael Silver, who we had on the podcast at Berkeley, whose team released the first edX MOOC, massive open online course on psychedelics, and then Al Garcia Romeo at Hopkins as well, who I think is doing some work on psychedelics and Lyme or tick-borne illnesses, so among many others. So maybe let's tackle psychedelics first, because we've been doing a lot around psychedelic assisted therapy coverage at Osmosis and Elsevier in the podcast. Most recently, we had the director of the NIMH, Dr. Joshua Gordon, on the podcast as well, who has been cautiously optimistic about psychedelic work. So maybe you can tell us a bit about the work, some of the highlights you and the Cohen Foundation have had in the space.
Yeah, sure. I mean, just give a little background on the Cohen Foundation before we jump into the psychedelics. Where organization is led by President Alexandra Cohen since its inception about 20 years ago. Alex focuses on US-based nonprofits. They're looking to help people, but also solve complex problems. So the psychedelics falls into the complex problems that we're looking at. And like you said, you mentioned size. We actually, as of last December, we just went over the $1 billion mark. So we provided over $1 billion for charitable support to underserved communities and children's health and education, the arts, Lyme and tick-borne disease, psychedelics, veterans, which I'll talk a little bit about later, and then sustainability. So I started in end of 2017, And then in 2018, we got more interested in the psychedelics field. It was sort of funny. As with most of our giving, it's inspired by Alex's personal experience. But she came to it via regular non-psychedelic mushrooms. So she actually was suffering from Lyme and tick-borne disease for many years. And one of the supplements that helps her is from Paul Stamets' Host Defense line of mushroom supplements. This is like turkey tail mushrooms for immune support type of thing. And so she became friendly with Paul Stamets and Louis Schwartzberg, who made the documentary, the film, Fantastic Fungi, which we also supported. And someone recommended Michael Pollan's book, How to Change Your Mind. And Alex read it and thought like that psychedelics might have like a potentially a tremendous impact. And so she wanted to learn more. And so we first called Rick Doblin at MAPS, who I know has been a guest on your show, but he wouldn't return our calls. So we joke about it with him now, but we literally couldn't get past his secretary. So we moved to the second name on the list, which was Roland Griffiths. And so we went down to Johns Hopkins, and we already had a relationship with them from some of the Lyme work. So we got an introduction from our Lyme researchers, and we sat knee to knee in Roland's tiny office and asked him what his big dream was. And a year later in 2019, the first psychedelics research center at a major US university was born. Our psychedelics portfolio, we fund a diverse array of indications from PTSD to depression, addiction, burnout, other mental health conditions, as well as pain disorders and infection-associated chronic illnesses like long Lyme that you had mentioned. Veterans are an important emphasis or focus for us. So the MDMA-assisted therapy for PTSD has been an important treatment that we've been supporting for many years. So we're part of the MAPS capstone, and then more recently, additional support. I mean, from our standpoint, it's just kind of like a shame that these breakthrough therapies have taken so long to receive mainstream acceptance and research funding. I mean, it's been 30, 40 years that they've been sitting on the shelf. And that's essentially like cultural, at least in my opinion, cultural stigma has restricted an objective evaluation of these treatments, which, really has, prolonged patient anguish, unfortunately. So I'm proud to work for someone who can transcend that, stigmatic social pressure and is unafraid to take bold steps in the hopes of helping people suffering from these chronic conditions that, unfortunately, the medical establishment underserves with other treatments. So, I mean, we have a vast sort of array of those research areas, but we also, want to focus on the system, kind of what I was mentioning before. So we've funded training of practitioners, including social workers and nurses at Columbia and UPenn. Safety is really important to us. So funding clinical guidelines as well as practitioner certification and making sure that we're getting, good ethical practitioners and well-trained. And then, of course, we're focused a lot on access because, again, it brings back to some of the, underlying ethos of the foundation is trying to improve services for underserved communities. And so we want to make sure that we've funded reimbursement strategies around getting on insurance. And then one of the areas that we've been funding more recently is in group therapy, because we think that will help drive down some of the costs and actually maybe more, honestly, maybe more effective for certain groups. I mean, you could think about veterans getting together, and it might actually be beneficial to be doing it in a group setting as opposed to individually. And then other sort of various field building and public education components, like he was talking about the MOOC and things along those conferences, things along those lines.
Yeah, what an incredible backstory and how much of an impact you and obviously Alexandra from her personal experience have made in 5 years on the entire space. We were both at the MAPS conference, Psychedelic Science, in June. I think we saw each other briefly there, and there were 11,000 attendees, and a lot of that would not have been, certainly much of it would not have been possible without, the legitimacy and credibility that came from the research studies that you guys have funded with MAPS. Obviously, Hopkins carried a lot of weight, Roland Griffiths, plus all of his collaborators, their work, and then Michael Pollan with his book. So who knows, if the money hadn't come in and Alexandra hadn't had that personal experience, how much longer we'd have to wait to get to where we are now.
Yeah, it's interesting to think about the role of philanthropy and these other groups, because, if we were waiting for the government to do this, I mean, we basically were. I mean, and they haven't funded anything for 40 years, 50 years. And so I think the role of philanthropy has to come in and oftentimes be the innovator. Right. And so I credit Alex with, having that burst of innovation around this and eagerness to lean in to those projects and put her name on it. Right. Because, again, there was a lot of stigma. A lot of people were maybe giving money, but not mentioning who it was from. And so We had, I mean, we joke because we had a lot of battles and controversy in the Lyme space, and then we get into the psychedelic space, and it was non-existent essentially.
Really? Oh,
Yeah.
fascinating. So before we go to Lyme, I'm curious, there's been so much movement, so much excitement, a lot of hype too, admittedly, in the psychedelic space over the last few years. Looking over the next 5 to 10 years, what are you most excited about, and the Cohen Foundation, you personally and or the Cohen Foundation, about psychedelics? Obviously, you mentioned a couple of things like group therapy,
Mhm.
which clearly, for certain indications, including, for example, substance use disorders, where
Yeah.
AA is already really effective method to help people stay sober, get sober, or stay sober. That combined with psychedelics could be very interesting. So yeah, what are you excited about for the next couple of years in the psychedelic space?
Yeah, I think addiction is going to be an area where there may be a lot of benefits. We're seeing it, psilocybin for alcohol use disorder, meth disorder. We funded one out in Portland at the VA out there. And the other areas, other psychedelic substances like ibogaine, you're seeing is gaining a lot of traction and may have some benefits. And so I think the idea is we're going to start to figure out how each psychedelic may have different benefits for different groups of people for different indications. And so it's still very nascent, right? We've done a lot in the last 3 or 4 or 5 years. And of course, many others like Rick Doblin, Baruchas have been doing work and rolling for 20, 30, 40 years. But there's so much that we don't know. So I think we're really excited, and also excited, it's going to be really complicated to see how these actually get put into sort of mainstream medicine. We see MDMA approval by the FDA likely in 2024, fingers crossed that everything goes smoothly. But it's a different dynamic for practitioners, right? It's a different mode of providing care. Typically a psychologist or a psychologist will not want someone to be in an altered state. And now we're actually asking them to put them immediately into an altered state. And so there's a lot of things that we have to learn from that. And we are concerned, as many with others, that you worry about the elite capture aspect of it. You don't just want it for people that have $10,000, $20,000 to be able to do it. We need to get the price point down so that we can make sure we have access to a lot more people that can benefit from this.
No, absolutely. And definitely, again, group therapy, telepsychiatry, AI could play a role potentially, as well as maybe novel compounds that are shorter duration, potentially, if you don't need one or two facilitators whole day to run a session in person, maybe only a couple hours. But before we go on again to tick-borne illnesses and chronic illnesses that are infectious in nature, I wanted to give you the opportunity to talk about veterans as well, because you mentioned that some of the work there. When Rick Doblin and Michael Mithofer were on the Raise Line podcast, Rick specifically mentioned that was a choice because there's obviously high need for veterans to get care, but also it's bipartisan. It's brilliant because, even at the psychedelic conference, we had former governor of Texas, Rick Perry, as well as governor of Colorado, Jared Polis, speaking, and it's very bipartisan in nature, the support that comes for doing anything we can to help veterans with PTSD and helping them not commit suicide, which is this staggering how many of them do that every year. So yeah, do you want to talk a bit more about veterans specifically, because you had alluded to that?
Generally, very much a focus area for the foundation. We have a sister agency, the Cohen's Veteran Network, which provides free mental health services to veterans and their family. It's about, I think we're at like 24 clinics across the country, mostly near, Army bases and military bases. And essentially we're their largest grantor, so it's a very close relationship there. And so we see it firsthand, like how difficult it is, to help, how challenging it is. And unfortunately, dealing with these veteran families, I mean, they're just, have this threat over them all the time, in many respects. I mean, I was just reading an article yesterday that they were saying, veteran suicide is down, and it's now 17 veterans a day commit suicide. And unfortunately that is, I guess moving in the right direction, but it's still so high. And so I think we need to be, we've been trying to provide as much help and support to veterans and their families as we can.
Yeah.
And we're hoping that, the MDMA, for PTSD and others, I mean, they're not different from many other groups in the country that can benefit. Maybe it's not PTSD, maybe it's depression, maybe it's, other mental health or addiction issues that they may be dealing with. And so we want to try to see, how this entire group of under-researched compounds may be able to benefit them.
Yeah, no, so many promising indications, not just for so-called abnormal psychology, but also, as you know, very well, having supported Roland Griffiths and his protege, Dr. David Yaden, who's also been on the podcast. Positive psychology, helping people flourish, because once we get them to normal, maybe we can help them be more creative, help them be more socially conscious, and maybe we'll have less need for veterans by not needing to have as many wars.
And I think that an extension from what you're saying is the normal, I don't say everyday happenings of life, but like things that happen to us, like the death of a family member, right? You do get, depressed and mourning, and there's grief, and sometimes it's not as easy to rebound from that. And these may be able to help in sort of times of whether it's shorter term depression, but maybe help with that flourishing as well.
Yeah. And one last thing on that point for psychedelics before we go into ICIs is that's why I really love the dyad study. I think you guys are probably involved with Sunstone. We had Bill and Brian Richards on the podcast, as well as obviously Manish Agarwal at Sunstone, which is doing this fascinating study of not just how these compounds can help people at the end of their life or with cancer diagnoses, but they're caregivers. And you yourself being a caregiver, most of us will be caregivers in our lifetime, not just of our parents, but also of children. And it's really hard. And so I'm crossing my fingers that this study shows some positive results about not just, again, the person, the patient, but also the caregiver being supported through these compounds or the therapy.
Yeah, no, I think it's such an important component, because oftentimes it's the caregivers that hold a lot of grief associated with the death or an illness, of what they could have done better, what they should have done, and so. And honestly, like some of the end of life issues that are talking about, the existential distress. I mean, this is some of the research that Tony Bassas has been doing for decades, but really, thinking about how that end of life experience doesn't have to be so emotionally painful. It can actually be an opportunity to connect with those people that are still here, and it actually can be a much more loving experience than as sort of depressing as oftentimes, unfortunately, it is.
Yeah, absolutely. So let's move on to Lyme and tick-borne illnesses, because the Cohen Foundation, the largest private funder in the U.S. of Lyme disease. So maybe you can give a highlight of how you guys got involved with that. Obviously, Alex's personal journey, and then some of the highlights of the work that you've done in this area.
Yeah, sure. Yeah, I mean, I kind of mentioned it before that Alex has suffered from Lyme and tick-borne disease for many years, and so she wanted to focus on finding innovative ways to improve diagnostics and treatments and sort of the basic research. So since 2025, the Cohen Foundation has given just under 100 million, probably hit 100 million by the end of the year, to Lyme and tick-borne disease, which is the largest vector-borne disease in the U.S. So roughly 500,000 people, 476,000 people estimated get infected every year. And in terms of funding on an annual basis, Alex Cohen, which is one private citizen, often spends more on Lyme disease than the CDC, which is a bit scary. And unfortunately, patients cannot access quality care for Lyme and tick-borne disease. So we're still using the same diagnostics and treatments from 30 years ago. Diagnostics are notoriously inaccurate. In particular, the standard two-tier tests are roughly 50% accurate in early disease. This is because they're an antibody test, and the body takes roughly 4 weeks to mount a detectable immune response in many people. But that's obviously, as a clinician, that's the exact time you want to be treating someone appropriately. So when they come in right after a tick bite, so clinicians need to treat based on symptoms, not the diagnostic results. And I would encourage everyone listening to watch the documentary The Quiet Epidemic to understand more about why Lyme testing is so inaccurate, and actually how the medical community has sort of failed to correct this over the last 30 years. Moreover, the standard treatments fail roughly 10 to 20% of the time, even with prompt treatment. So this leads to long Lyme, or what oftentimes researchers called post-treatment Lyme disease syndrome, where patients have prolonged, often debilitating symptoms for years, or oftentimes even decades, unfortunately, with some people. So you can do a little fast math with 500,000 people getting Lyme each year, 10 to 20% having treatment failure. Even with prompt treatment, there's an estimated 2 million people in America with long Lyme, and that's not my number. That's a number quoted by CDC, and that's roughly the same population as Alaska, Vermont, and Wyoming. So imagine Alaska, Vermont, and Wyoming all had the exact same disease, everyone there put together. And unfortunately, the sad news is that there's no treatment guidelines for long Lyme. So I have a pop quiz for you, Shiv. When was the last time NIH funded a clinical trial on long Lyme?
Ooh. just based on your framing of it, I would have to assume it's been decades.
It's not last year.
At least a decade or more.
Yes, 18 years to be precise. I mean, essentially that like NIH has abdicated their responsibility to find any treatment options for these 2 million Americans. And that's not even getting into the issue of, ticks can carry more than one disease. Another pop quiz. How many diseases do ticks carry?
Dozens, I feel, right? There must be a lot. Yeah.
Yeah. Last time I checked, which again is important because we're adding new ones every few years, but it was 18.
Yeah.
So around 20. Like is a good guesstimate. And so last question for you.
Yeah.
How many clinical studies have been conducted on patients with more than one tick-borne disease?
Less than 5.
Zero.
Okay.
Right. So as a clinician, like if you see someone coming in with multiple tick-borne diseases, right? How do you treat them? Like you have no evidence-backed, science to do anything with them. We assume that you treat them, you treat the Lyme first, and then you treat the Babesia or the Bartonella or whatever, second, and we assume that will work, but we've actually never tested it. And you're asking, how much, we've done studies on ticks, and roughly, and this is in New York and Connecticut, 56% of the ticks had Lyme disease, and 19% had an additional co-infection. And then other studies, we've looked at, this is samples from US and Europe, blood samples, about 65% of those with the one tick-borne disease had a second. Now, again, there might be obviously some bias. Those are the ones that are getting in because they have a tick-borne disease. But clinicians are going to be seeing a lot of this, and unfortunately, they don't have the necessarily evidence to be able to treat them well. And so that's a challenge, right, for those clinicians, that they're left in a very difficult position to help deal with this patient. So, over the last 8 years, in the face of this sort of NIH abdication, Alex Cohen has taken the leadership role in trying to find treatments for people with long Lyme. So the Cohen Foundation has funded like many basic and translational research projects. Currently, we have a diagnostic prize competition called LymeX, which is a public-private partnership with HHS. And so it's about a $10 million prize to getting new Lyme diagnostics through the FDA. We're funding clinical service centers in hopes to help patients like immediately. And these are, major universities. And then we've funded the first clinical trials network for Lyme and tick-borne disease in 2020. And so, we're looking to clinically evaluate various treatment options and disseminate that knowledge about effective clinical care so we can, help the masses, hopefully across the country and across the world. Obviously, a few clinical centers are great, but they're obviously not going to treat 2 million people. So we need to, find what's working and then disseminate it.
Yeah, incredibly comprehensive. Again, the approach you guys take from bench to bedside to policy. One thing I was going to say is, obviously this year we call it the year of the zebra. We're focusing on rare disease awareness. And at one point, I'm sure many of these tick-borne illnesses are still considered rare diseases. The definition in the US for a rare disorder is it affects fewer than 200,000 Americans. And obviously Lyme already affects over 10 times that amount. And we're worried about, climate change maybe contributing to this problem, making it worse.
Oh yeah, especially with ticks. Yeah. Well, and I think it's great because I really like what you're doing with Year of the Zebra. And I would joke about this too, was that Lyme used to be a zebra and now it's a horse, right? In terms of like the idea that, when you hear hoof bleeds, you should think horse, not zebra. But unfortunately, clinicians were oftentimes may have that mindset that it's rare. But in actuality, when, there's sort of sudden onset body aches and joint aches and all these things in the summertime with a 9-year-old, you really got to be thinking Lyme. And with a test that's not accurate, you have to be relying on your own judgment and clinical judgment more in that context, because it can be debilitating for that child. And by the way, I should say that, we have this, large portfolio with Lyme and long Lyme, but recently in the last few years, we've expanded it to include other infection-associated chronic illnesses. So long COVID, chronic fatigue syndrome, ME/CFS, MS has an infection initiator. And so we just actually announced support for a clinical center at Mount Sinai with Dr. David Petrino, which will treat patients with all these infection-associated chronic illnesses and hopefully provide opportunities for other clinicians to learn from their clinical experience as well. Because we're seeing a lot of, compilations, very similar symptom set, from long COVID to ME/CFS, these fatiguing syndromes. And so we try to think a lot of times as clinicians, like when a patient comes in, it's not you've got to have that differential diagnosis and really understand, try to figure out which one it is. It's not always easy when there's so much commonality between these infection-associated conditions, chronic conditions.
Yeah, no, absolutely. I was gonna mention that the Cohen Center for Recovery from Complex Chronic Illnesses, which, we've had people like Dr. Lisa Sanders on the podcast, who's leading the Yale Long COVID Center.
Yep.
And it's really, obviously the silver lining of the COVID pandemic is that there's so much interest in long COVID, right? Which hopefully legitimizes and brings more credibility to some of the issues that people have faced for decades now, where the paternalistic, medical, not just research establishment, but medical care establishment that says, oh, the pain is in your mind, or, that doesn't really give attention to some of these patients. Hopefully that tide is turning again because of more people who are influential getting these conditions, more influential universities like Mount Sinai, which you're funding, and Yale, doing research on these conditions. So I think the tide is hopefully turning. I don't know if you feel like the progress, it may not be fast enough, but do you feel the same? Like now in the next decade, we should be seeing a lot more improvements?
I think so. I mean, I think it was slow, right? ME/CFS, chronic fatigue syndrome, it took a long time to get acceptance in the medical and research community. Long Lyme took very long, been controversial process over the last 30 years. And then long COVID came, right? And the issue with chronic fatigue and long Lyme is it was a trickle, right? There's a few tens of thousands of people getting it every year. And so I think it was more easily dismissed. When long COVID came, it was millions of people all at once. And so it's funny because you actually saw the same denialism in the beginning. And it's funny because I was talking to a lot of these groups and be like, oh yeah, this is going to say this next, and they're going to say this, and they're going to say this. And, but of course, with so many millions of people having it, all at once, it was too hard to deny. And so I think there was, a lot of credibility, and people realizing that they need to focus on it. And, in that context, actually, I will say NIH did fund some work there. So they definitely put resources behind long COVID in the last few years.
Very good. Well, so as someone, again, you have an interesting hat because you're both someone who's personally caring for someone or family member with long Lyme, but you have also helped fund dozens, if not hundreds, of organizations and individuals doing research and clinical care in the space. What advice would you give to our audience, mostly current or future healthcare professionals, first about, like, say someone comes to their clinic with maybe a new diagnosis of Lyme or a related infection-associated chronic illness, having worked directly with clinicians, what advice would you give them about that interaction?
It's a really good question. I mean, I know you guys are a learning company, right? And honestly, I'd love to have, videos around, how clinicians should treat patients where the diagnosis is unclear or the treatment guidelines are limited or even non-existent, right? It's very complex, right? And to take a line from the journalist Megan O'Rourke is, how do you treat someone who is, quote, living in the body on the edge of medical knowledge, right? You have to have empathy. Right? You have to have those detailed conversations with the patients to talk about possible treatment options and to talk about diagnostic options, right? Because you're still trying to figure out what it is. Talk to them about the risk profiles and let the patient make that informed decision. And most of all, be humble. Tell the patient what you don't know. We've gone through dozens of doctors, and the ones that we appreciate the most were the ones that said, like, hey, have those honest conversations. And then when we get to a point and be like, hey, I don't know how to treat you. I don't know where to go to next. Maybe we should talk to this person. Maybe we should talk to that person. Like, really felt like you were a partner in the process and less, sort of dogmatic in their approach.
Yeah, that is great advice, and definitely something we're excited to be able to work on, because a lot of Osmosis has been focused initially for the first few years on, like, just explaining what we know about these conditions that help you pass your exams to become a doctor or a nurse. But increasingly over the last few years, we've done a lot of the so-called soft skills, which become the hard skills. How do you become an advocate for your patients? How do you leverage new clinical decision-making tools that have AI to maybe get to a diagnosis faster? Because I'm sure that's been one of the most frustrating things for people with long Lyme, is just years and years or chronic fatigue. It's just getting to diagnosis, which again is a common theme we hear from rare disease patients as well. Really, any condition that either due to lack of awareness or willful dismissiveness among clinicians, I think could benefit from this type of educational content.
Oh, totally. I mean, that's another area that I think, just sort of injecting that humanity into the clinician-patient relationship, clinicians leaning on their empathy, compassion, and meeting the needs of the patient. And, we talk about treatment guidelines and, they should be guidelines, not like a tool to unjustly stunt patient options. Because oftentimes guidelines are built on weak evidence, underpowered studies, looking at average effect sizes. That's typically a far cry from precision medicine. And you guys always talk about precision medicine. That's, oftentimes that's not. And in the areas where NIH or philanthropy does not fund, you may not have any science-backed guidance at all. And I know, kind of what you were alluding to, I know patients who are fearful to go to the doctor, right? Because the doctor, negates their experience or symptoms or chalks it up to psychosomatic. But it's often just a patient that the clinician doesn't have answers for yet. And, that's really frustrating. And it can be dehumanizing when you have this debilitating disease and the people that are trained to help you just dismiss your suffering. And it's funny you bring up AI because I think about this a lot, with the advancement of AI. I personally believe there'll be an increased pressure to remove costly elements of the healthcare system, such as physicians, to be replaced by less costly AI, right? So if clinicians do not connect with their patients through their humanity, then replacing clinicians with non-human intelligence seems inevitable.
Yeah, that's a theme that's come up as well in the podcast. We've had people like the head of data science at Stanford, Eric Topol, who's obviously written a lot about AI in healthcare. And I agree, like with AI replacing maybe just rote memorization and knowledge application that comes from why you would go to a so-called expert. When you have an AI that can read millions of research papers, case reports, ranging from case reports to clinical trials, and is most up to date in all the guidelines, evidence-based guidelines and non-evidence-based guidelines, by plugging into data sets that also include maybe Eastern medicine traditions, indigenous medicine traditions that most of us get very little, if not any training, let alone, I mean, when I was at Hopkins Med School the first time around, I got 3 days of nutrition training. That's it. For something where, food obviously affects a lot of chronic illnesses. So an AI will replace a lot of the memorization aspects and application, which means that I think hopefully our listeners will double down on the things that make them most human.
Exactly.
The so-called soft skills, which become the main skills, I think, that help people change their behavior in the case of lifestyle-associated chronic illnesses, or feel supported, feel connected in the case of every other kind of condition, or really any sort of medical issue that comes their way. While we're on the topic of advice, I was just going to ask more broadly. You've had a very interesting career. It still continues to evolve. What advice would you give our listeners about approaching their careers in healthcare or public health, et cetera?
I think one thing obviously that's worked for me is finding something that you're passionate about. It feels a lot less like work when you've got that passion for the role. Obviously, young career folks, I always say, take your internship seriously. I've had a lot of interns at the UN and at the foundation, and you'd be surprised at how little some young folks take internships. When in my experience, they've turned into jobs and they've turned into very important components of my career. Yeah, I think it really rests on finding that passion. I think is really valuable, and finding where there's so much need. Finding the areas that people aren't working, the road less traveled. You'll find a lot of folks there that really need your help, and especially many people get into the field to really help people and make a difference in people's lives. And I think there's so many opportunities to do that. I know it can feel, I'm sure from a clinician, it can feel very hard because there's so many other pressures on you, whether it's the financial aspects or insurance requirements and all these other things about either running a business or falling in line within a large behemoth health system. But I think keeping that focus on helping people and being open to identify help for yourself. As a caregiver, I know how much people oftentimes need support when they need support, but I also like to remind other caregivers that they're a person too and need to take care of themselves. It's one thing. Back to our psychedelics discussion, we did fund University of Washington for burnout in frontline health workers, because we see it can be debilitating. I mean, your jobs at the front line can be so demanding and so emotionally demanding too, especially in certain fields, so close to that emotional mortality experiences of people that are old and young. And so it can be really, I think, challenging. And so you need to take care of yourself along the way.
That's wonderful advice. And that was actually one of the highlight talks I went to at Psychedelic Science was the Washington study. I think that's great advice, self-care and finding the passion. And obviously it's led to a lot of high leverage impact that you and the Cohen Foundation have had. So my last question for you is an open mic. Anything else that you'd like to tell us about you, about the Cohen Foundation, the space that we haven't covered? So anything you want to share?
Yeah, sure. I mean, we talked a little bit about it around NIH and their funding. I mean, it's an area that I think about a lot. Obviously, we play sort of go hand in hand with some of the NIH funding, and there oftentimes philanthropy is filling in gaps that may not get funded from governmental institutions. And their role in selecting grants, I think, is probably the most important thing that they do, right? As a pure function. It's about $40 billion in NIH a year. 80% of it, is external. So most of it is giving grants out to other people to do the research. And so selecting those grants, I think, is probably the most important function that they have. And unfortunately, in many conditions, you think, we're talking Lyme, we're talking, oftentimes other areas, whether it's Alzheimer's or chronic fatigue syndrome, and other areas that don't have real solutions and real innovation in the last, several decades. I always kind of wonder if, there's an opportunity to, think about a new approach to selecting grants. I mean, they only do peer review process, and that has its pros and cons, right? So, one of the pros is that you're asking other peers to evaluate these grants. And so it tends to be risk averse, which is good for, when you want to take care of, taxpayer dollars, right? That's an important feature. But the problem is it oftentimes maybe too risk averse, and it doesn't, benefit innovation. And so there's very little innovation that happens from that. And there's obviously inherent biases, because essentially people that are reviewers have to have been selected to get a grant before, is my understanding of the process, right? And so it's almost an exercise in a groupthink, right? Is that you can't ask people to be innovative if they all kind of think relatively the same, and so they're sort of selected into this group because they think the same oftentimes, or have similar, thought processes or the ways they approach a certain condition. And so, not to what I would say they throw away peer review. That's not my proposal, but I would argue that maybe we actually have a second track, maybe having 20 or 30% of the funds going to more of an innovative way of, for lack of a better word, trying to hit home runs. And so really focused on innovation. And yeah, you're probably going to have more strikeouts, but you may actually advance these fields in an effective way. And secondly, you have an opportunity to then compare the two, right? Because you can compare, like, are we actually doing better in one or the other? Are they complementing each other? Like, sometimes you need to take a big swing, get yourself to over a certain hurdle, and then the more risk averse option can fill in the blanks. So it seems to me that you kind of need a comparator in this process, because with NIH being so scientifically oriented, their main function of selecting grants, they don't have a scientific method to evaluate themselves in that process. Now, I'm sure they're working on stuff to make the peer review more, on the margins better, over time. But I would think we should think through other options and seeing how they compare relative to peer review, because, like I said, it's good to be conservative with taxpayer dollars, but at the same time, we haven't had innovations in these certain fields for 20, 30, 40 years. So, like, my taxpayer dollars are helping someone in 2050, 2060, 2070, right? I think a lot of people say, like, no, actually, I need you to help, me and my family, like, now. I need these things to happen in the next few years. So trying to find different options to do that would be valid. Anyway, that's the kind of stuff that I think about.
Yeah, no, it's super important and very relevant, again, because, we've just spent the last 30 minutes discussing the important role philanthropy, the Cohen Foundation, has had to vastly accelerate these fields. And it would be amazing if, some of that $40 billion that the NIH spends every year could similarly be earmarked for super innovative field advancement, as you guys have done. So hopefully some of our listeners who decide to go into research careers, MD, PhDs or whatnot, may find themselves at these governmental agencies or academic labs or private foundations, take that to heart and can collectively help change or reach out to you. As the last question, if our audience is interested in connecting and learning more about the Cohen Foundation or you, where should they go to learn about?
Website's probably easiest, www.steveandalex.org.
Awesome. We'll make sure to drop it in the show notes as well. So, Ben, I'd really like to thank you for taking the time to be with us on the podcast, but more importantly, again, for the work that you have done over the past several decades, really across global health and now with the Cohen Foundation to accelerate work in psychedelics and tick-borne illnesses, among other areas.
Well, hey, thank you so much. I appreciate you giving us the time.
Totally. And with that, I'm Shiv Gaglani. Thank you to our audience for checking out today's show. And remember to do your part to raise the line and strengthen the healthcare system. We're all in this together. Take care.
If you like this podcast, please share it on your social channels. You can also subscribe to the series and check out all of our episodes at osmosis.org/raisetheline podcast.